everybody to this week's happy hour session. And we're very privileged and pleased this evening to have Dr. Victor Prieto hosting our session. Dr. Prieto is Department Chair of Pathology and Director of the Dermatopathology Division at MD Anderson Cancer Center in Houston. Also serves as co-director of the Melanoma Tissue Bank, and certainly has done extensive cutting-edge research on melanoma. He's an excellent teacher. I've been in Houston for how long now, Dr. Prieto?
Well, 21 years in Houston, so.
That's great.
Time flies.
Yeah, exactly. So anyway, we're pleased to have him running today's session, and I, like you, I'm anxious to hear what he has to say. With that, I'll turn it over to you. Thank you.
Well, thank you, Dr. Davis. Thank you, Sagis, for organizing this get together, and especially thank you for that very kind introduction that I'm already flashing. But so thank you again. So Dr. Davis was so kind to select a few cases that to make a potpourri, just to show you some cases in which they have either differential diagnoses that are important to know, or they are difficult diagnoses. And I'm going to use them as a way of discussing a few topics through the hour. And without further ado, this is a shave biopsy. And you can tell it's a shave because it tapers all the way to the edge rather than being a square, in which we can tell at this power that it has a hyperkeratosis and hypergranulosis. If this is normal area of the skin, you know that we're dealing with acral location. So I don't see many hair follicles. So probably we are somewhere either on the palms and the soles, although the soles usually have a thicker sternum corneum than this one. Obviously, what is getting our attention is the dark color of the pigment that we see in the dermis. When you consider pigment in the dermis, there can be two different sources. It can be internal pigmentation, which most of the times would be melanin or hemosiderin, although it can be some deposition of other products. But in general, at least in Dermpath, this is what we tend to see. And if it is external, by far the most common scenario will be a tattoo. So the other thing that we can see is that this pigment that we see is limited to the dermis because the epidermis has, by the way, Dr. Davis, just to make sure, you guys can see my mouse, correct? Anybody?
Yes, we can see your mouse.
Okay, perfect. Yeah, I was worried that I was pointing, and then people were thinking, what the heck is he doing? So you see the epidermis that it has no pigment at all. So the pigment is concentrated in the dermis. The other thing that is important to see is that there are probably two areas. The area that is closer to the epidermis that is heavily pigmented, and the areas that are deeper located. Those have a combination between the pigmented areas and the fibrous stroma. That's the pink area. So let's go higher power. And again, we confirm that the epidermis is spared by the process. That it doesn't help us much to know which type of pigment it is, because you can have a melanocytic lesion that is purely intradermal. On the other hand, if you had pigment in the epidermis, that would be unlikely to be a non-melanocytic lesion, because pigment deposited in the stratum corneum is not going to be tattoo, but it's going to be by far the most common scenario will be melanin pigment. So let's go higher power. And what we see, these linear structures, those are endothelial cells, probably endothelial cells. Endothelial cells which is telling us that basically everything that contains melanin pigment, let's not get ahead of ourselves, are cells, the same cells have. Now, let's go to the area that had fewer cells. And we see this, that in most of the cells, the quality of the pigment is very granular. Like in this one, we see, and those are probably the same granules. They're small, and they're compacted one to each other. Now, the quality of the pigment, if I could just flip the condenser, you could see that this pigment is not refractile. So it doesn't become brighter at the time of flipping the condenser. That's usually a clue that the pigment, when it becomes bright, that's a clue that there is hemosiderin and not melanin. So this one, the brownness of the color and the fact that where you be able to flip the condenser, it wouldn't be bright. So that becomes that it's melanin. Now, if it is melanin, you can have two possibilities. You can have melanin that is present in melanocytes, or you can have melanin that has been phagocytized by macrophages. Now, for this particular lesion, actually, let me jump. And let me show you. This is the morphology that you typically see in most melanocytic lesions in the skin. You have those pigmented cells that we saw with the granules, the macrophages, alternating with the melanocytes. So if you notice, most of the pigment is a granular pigment there, and there are only a few cells that have very, very fine granules. And those are probably melanocytes. So macrophages, melanocytes. Now, if we alternate with what we saw in this one, basically all the cells are the same. So that means that whether they are macrophages or melanocytes, they are indistinguishable. And that's one of the clues that we use to make a diagnosis of this lesion. So there are two main differential diagnoses. One of them, it's benign, obviously, and one of them is actually not exactly benign, but it's somewhere in between. So for a malignant diagnosis, the most likely scenario for this would be a completely regressed melanoma. And nowadays we can see that in patients that receive targeted therapy. So patients treated with nivolumab or pembrolizumab can have that, in which almost all the cells die and the pigment is phagocytized by melanophages, or in some patients with BRAF mutation and receiving anti-BRAF treatment, they can have also complete regression. Now, if you notice, there are a few cells, in particular this cell, this, and this cell, in which we see visible nucleolus, but there's very little pigment. So those are, with all likelihood, melanocytes that are not heavily pigmented. But by far, most of the cells are heavily pigmented. So that becomes what this diagnosis is. And it's a pigmented epithelioid melanocytoma. This term is the current term that was popularized by Dr. Arthur Sembowitz from Boston to replace the term originally proposed by Dr. Wallace Clark of animal type melanoma. And he used the term animal type melanoma because most melanocytic lesions in animals, particularly horses and dogs, have this type of pigmentation. So melanocytes are heavily pigmented in contrast to what we see in most melanocytic lesions. And obviously, if you are a patient with this type of lesion, probably you would not be happy if your pathology report says animal type melanoma. So that's the main reason why it was replaced by pigmented epithelioid melanocytoma. But please notice that I'm not calling it pigmented epithelioid nevus or pigmented epithelioid melanoma, but rather melanocytoma. And this was suggested because the vast majority of these lesions do not kill the patient. So they have a very, very low mortality rate, even though they can metastasize to the lymph nodes, to other areas in the skin. And from the original series from Dr. Sembowitz, there was one patient that had a metastasis, single metastasis to the liver. And up to the last follow-up, and I asked Dr. Sembowitz 2 years ago, the patient was still alive, which would be really exceptional for any melanoma metastatic to the liver. So points to remember about this lesion is that melanocytes are heavily pigmented, the same as macrophages. And let me again jump to PowerPoint. So this will be the typical morphology of a pigmented melanocytic lesion, either a blue nevus, cellular blue nevus, or deep penetrating nevus that we'll see in a moment. And compare with this one, in which most of the cells are heavily pigmented, which would be a pigmented epithelial melanocytoma. And I believe that we will have some time for questions at the end. So please make sure that either you save them for the end or you use the chat to include them. So let's go to the second lesion. And we have a few differences now. We don't have hyperkeratosis and hypergranulosis. We have a few hair follicles, not very prominent. So this is likely not acral, likely not on the face or head or neck, but rather somewhere on the trunk, possibly chest or back or proximal extremities. And we have two components in the lesion. We have a junctional component that we can see here that is primarily, let me go higher power, that is primarily nests with very little pagetoid upper migration. These areas have also melanocytes in the dermis. They're forming small nests. And then if we go to the other side, we see almost the opposite. We see primarily a dermal lesion with very little junctional components. So let me go low power again. And you can see the difference between this and this area. So for the first one, since we have just elongated Warty ridges, not much pagetoid upward migration, and primarily a nested pattern of growth, this is a nevus. Now, the fact that we have peritrabecular, peri-Warty ridge fibrosis, lamellar fibrosis, a few macrophages, vascular proliferation, and a few lymphocytes, that will qualify for this lesion to be a dysplastic nevus. But that would be only a nevus. Now, let's forget for a moment, except for the fact that we see that the same melanocytes that we see in this area of the nevus, they come to this, and then immediately we have this area, adjacent area, that has much bigger cells. So let's go higher power, and we can compare in this. Smaller melanocytes that, remember, they come from the right of the slide, and larger melanocytes. The nuclei of these cells are larger than on the first ones. The cytoplasm is also larger. And when we go higher power, I think this is the maximum we can go, there is pleomorphism in the sense that we have larger cells with visible nucleoli, large nuclei, alternating with cells that have much smaller nuclei, and other cells that have hyperchromatic nuclei. So there is pleomorphism. Now, one thing that is important to notice is that mitotic figures are not evident. I mean, I can spend a long time looking at it, but I would bet you that we will see very rare melanocytes. Melanocytes with proliferation. And the other thing that is important to notice in these lesions, that they have a lymphocytic infiltrate. So let's go to the other half of the shave, of these lips. And then we have still the area of dysplastic nevus. and a third component in which it doesn't even have the features of this plastic. Now, since I don't have the clinical history, I cannot tell you if these are 3 different lesions that were placed in the same container, or if this is the same specimen that has been dissected, or even better, if this and this correspond to one shape and this corresponds to another. But regardless, we have a nevus here. We have a nevus here. So the question is, what are we going to call this? If we had only this one, the cells themselves have features that you can call a schizoid. Schizoid meaning large cells. They have large cytoplasm, large visible nuclei with visible nucleoli. And by definition, should have very few mitotic figures. And if any mitotic figure is identified, it should be close to the epidermis or close to the hair follicles or the skin adnexa, but not down deep. So once you know this pattern of the dual morphology of small melanocytes, larger melanocytes, you have basically 2 scenarios. The main one that you want to rule out is melanoma arising in the nevus. Now, for melanoma arising in the nevus, one thing that is important to see is that the melanoma cells have a pushing border, and they push the melanocytes, the benign melanocytes, outside. But please notice that we have the same cells that we have here, we have them here, and they mix imperceptibly with the larger melanocytes. So that would be exceptional in any melanoma, because melanomas, what they do is when they infiltrate, and if you have been able to listen to any of the lectures of Dr. Bernie Ackerman, melanomas invade the dermis, even though he didn't like the term of invasion because he thought that tanks invade, but cells do not invade. But basically what they do is they have a pushing border in which melanocytes push everything that is around them. But if you have a benign proliferation, melanocytes mix with the others. So this is better for a combined nevus than for a melanoma rising in a nevus. So since we know that it's a nevus, there is one that has exactly this morphology, meaning biphasic with benign melanocytes and larger schizoid melanocytes, both without proliferation pattern. So once you know what this could be, you have to go, you have. One of the best things that you can do is BAP1, because BAP1, as you know, is a BRCA-associated protein, number 1. It's a nuclear antigen that is present in almost all the cells in the body. So in this particular one, you can use your internal control, which would be the epidermis, and we have a wonderful positivity of the nuclei. Now, the majority of these lesions have the benign appearing melanocytes preserved BAP1 expression, as in this one, but if we go to the larger melanocytes, if you look at the nuclei are negative. So we have a few cells which are probably endothelial cells, but the majority of the melanocytes there again are negative. So this supports the diagnosis of a BAP1 deficient melanocyte, a melanocytic lesion. We discourage the term of BAPoma. First of all, because oma refers to a tumor, any tumor. And second of all, because it would be more than a BAPoma, it would be a BAP negativoma, because those are not BAP positive. It's actually, these cells have a mutation of BAP, and BAP is not expressed. And the other thing that is important, and again, let me jump on the presentation, is that these lesions behave in more than 90% of the cases as a benign lesion. So if you look at HMB45, they should be negative, as in this case, and let me move out. Only a few cells are positive, and possibly that's a melanin pigment. And then if you look at the double marked one, and Ki67, you can see that the cells have a beautiful positivity in the cytoplasm, but the nuclei are negative. Maybe we have one lymphocyte there, but most of the cells are negative. And the other thing that is important in these lesions is that they have a mutation of BRAF. So if you have the antibody against BRAF V600E mutation, the cells will be positive. So this is a different case, but you can see again how the PAP1 is expressed in internal keratinocytes as internal control, is negative in the large epithelioid melanocytes, and the BRAF V600E is positive in those cells. And clinically, these patients may have dozens of melanocytic nevi, which are basically indistinguishable. This is from the first publication from the group of O'Shea. And the other thing that is important to remember is that these patients, even though these lesions are mostly benign, they may have melanomas, other melanomas. They may have ocular melanomas, and also importantly, they may develop some internal malignancies, such as mesothelioma. So remember that we have two components, the large spitzoid cells merging with the benign appearing nevus cells. And this is probably the explanation of why we have this combination of the BRAF and the BAP1 is that there's a second hit because the original nevus was already mutative for BRAF. The vast majority are benign, as I was saying, so we don't like the term BAPoma either. So we call them nevi with BAP1 deficient. But however, we've seen at least 4 cases that had all the histologic criteria for malignancy, meaning pleomorphism, meaning proliferation, and meaning pushing border against the normal melanocytes at the periphery. And basically, we consider there is a spectrum between the benign, and we call nevi, obviously, and the malignant that we call melanomas. So let me go back to the next lesion. And Dr. Davis was so nice to group them. So you can tell that probably is going to be another melanocytic lesion, just a giveaway. And because of the topic, it has also marked pigmentation, because most melanocytic lesions, if any, they have pigmentation of the basal keratinocytes and the superficial melanocytes. But please notice on this one, we have pigmentation all the way down to the bottom. Now, we have a wedge-shaped lesion, and that's important because it's most likely associated with a benign diagnosis. We have only focal junctional component without visible pagetoid upward migration. And we see that the cells are basically similar size-wise on the top, the bottom, and then at the base. As you know, this is one of the features we look for maturation. And in theory, benign lesions should have larger cells closer to the epidermis with larger cytoplasm, more pigmentation, and forming larger nest when compared to the deep. But please notice that the cells are basically the same as the ones that we saw on the top. They have very similar amount of melanin pigment, and they have very similar size of the nest. So this is one of the few exceptions to the rule of change from the top to the bottom, namely a maturation pattern. And so this lesion belongs to the group of heavily pigmented melanocytic lesions that go all the way from standard blue nevus, cellular blue nevus, and this, which was coined as a deep penetrating nevus, and for other authors, it's just another type of blue nevus. Now, interestingly, in the last few years, this lesion It has been reported as having mutations at beta-catenin and having expression of cyclin D1, which would make it different from the standard blue nevi. And these two observations probably support the idea of separating them and consider them in a different group of lesions. Similar to what we just described with BAP1 lesions, the vast majority of these will behave benign, but not all of them are. And actually, from the very first paper that there was Dr. Kutzner, one of the lesions actually gave a metastasis afterwards, so it was not benign. Otherwise, we're going to have the same features as we would see in benign lesions. So since this is a heavily pigmented melanocytic lesion, HMB45 tends to be strongly positive all throughout, top to bottom, right to left, and proliferation is very low. If any, a few melanocytes may show a single or two mitotic figures at the upper portion. Proliferation rate will be low, and it should be overall less than 5%, and those cells should be located in the upper portion and not in the deep portion. So this is a deep penetrating nevus, and it's a benign lesion. And I believe that the other fragment is basically the same. Again, we have, let me go higher power just to highlight the difference between these and a pigmented epithelial melanocytoma, because we have the heavily pigmented cells, which are the macrophages, and the cells in between, they have a hint of melanin pigment, and those are melanocytes. So let's go to the next one. And we're going to leave the chapter of melanocytic lesions. We're going to change to what Monty Python used to say in a flying circus. Let's go for something completely different. So let's go low power first. We see prominent hair follicles, visible acrine glands. So we're probably somewhere either on the head and neck, or if any, on the upper back or upper chest. There is a slightly thickened stratum corneum, a slightly thickened granular layer on top of the lesion. But if you look at the periphery, and let me go higher power, this would be the normal thickness of the epidermis. So it would be a few layers of keratin, 3 layers of granular cells, probably 6 to 7 spinous layers, and 1 basal layer, which in this case, and also supporting the interpretation that we are close to the face, has pigmentation of basal keratinocytes, as what you can see either in lentigo or in early seborrheic keratosis. But let's go to the lesion. That is very interesting. First of all, when we look at low power, it almost feels that this is a follicular cyst because we have an opening, we have granular cells, so it would be an infundibular cyst. However, infundibular cysts, their wall should have similar morphology as the one that we see in the epidermis, meaning that we will have basal cells, there will be suprabasal cells, spinous cells, and granular cells. However, if we keep going down, we see something that would be very unusual for a follicular cyst, and it's acantholysis, as defined by separation of keratinocytes one to each other. And that becomes so prominent that the cells fall apart. This process is due to loss or damage to the intercellular bridges, the desmosomes, while the hemidesmosomes are usually preserved. As you know, the hemidesmosomes are the ones that join the basal keratinocytes to the basement membrane in the epidermis, or in this case, in a follicular cyst. But in this one, what we have is the keratinocytes that are above, they become separated. And we have something else on the top that we see that the keratinocytes in the stratum corneum still maintain the nuclei. So this would be parakeratosis if you put it on the top of the epidermis, and here they're called grains. And if you know the word grain, and those are choroon. So basically this is an apoptotic cell with heavy keratin concentration in the cytoplasm in the wrong place, because this cell should be up in the stratum corneum and not admixed with the keratinocytes. So this gives you a very interesting differential diagnosis because we have an acantholytic process. Depending on what you practice, acantholysis can be seen in more frequently in one or other processes. For example, for us in MD Anderson, since we are a cancer hospital, most of the times that we see this acantholysis as a lesion, not as an incidental finding, as a lesion, will be associated with herpes infection. And because many of our patients are immunosuppressed and they are at higher risk for zoster or for herpes simplex virus. Now, in regular life, the most common scenario for this particular process will be seen only in the epidermis. So it will be the same acantholysis will be seen here, and that will be on the upper back or upper chest, and it's called Grover disease, or it's focal acantholytic dyskeratosis. If this process is extensive and involves the axilla, we will be dealing with Derriere disease or Haley-Haley, because both can have acantholysis, choroon, and grains. Or it could be associated with pemphigus if we had, again, a diffuse process. Now, this one, with all likelihood, is a localized lesion. And you can use two clues. And again, I'm using a term that Dr. Bernie Ackerman popularized. So one clue is the fact that this biopsy was shaved. And most of the times when you receive a specimen that is for a rush from a cutaneous eruption, they're usually taken either with an ellipse or with a punch, because a punch is allowed to see a deeper component of the dermis. This one was a shaved, so it makes me think that this is a single lesion, because it was thought to be either inflammatory, like a folliculitis, or a follicular cyst, or neoplastic, like a seborrheic keratosis, basal cell carcinoma, or superficially squamous cell carcinoma. Now, the other thing that makes me think that this is a single lesion is the fact that we see all this keratosis associated only with this structure that may or may not be a follicular cyst, but not at all in the epidermis. So because of these lesions, I think that this is a single lesion, and of all the possibilities that we mentioned before, since they would be either superficially only in the epidermis, or they will be associated with a rash rather than a single lesion, this would be a warty dyskeratoma. And it's called warty or warty because it has this area that it could be a papillomatous and it can resemble a wart. And obviously the term dyskeratoma is because we have the dyskeratosis, meaning we have acantholysis, cells separating one from each other because of damage to the desmosomes. Choroon, those are round bodies, if you prefer in English, and the grains. And all these features are typical of Derriere disease, but in this particular case, it's just a warty dyskeratoma. Okay, so let's move to the next one. And this is a very important diagnosis because it's one of the situations in which you can save the patient's life just by establishing, and I'll tell you why. But let's go first at low power. First of all, we have very prominent sebaceous glands and multiple hair follicles. That makes me think that we are on the face. So we are on the face and we have a structure a proliferation of keratinocytes, very typical. And we can compare those. Let me go to the left. Here we go. So we can compare the size of this atypical cell in this proliferation with the adjacent keratinocytes. So this is much, much more atypical than that one. And we see similar cells that will go up into the epidermis. Here we go. There. And they are admixed with the normal keratinocytes. So if you have these cells, and if you knew that those are melanocytes, you would immediately call this melanoma because you have atypical cells with pagetoid upward migration. Now, are these melanocytes? And please notice that the junction between the tumor cells in here has a beautiful railroad track. Those are just desmosomes. They are joining one cell to each other. Here's another one. Here's another one. So those are keratinocytes because the only cells in the skin that have desmosomes are keratinocytes. Well, sorry, keratinocytes in a sense that it could be coming from the epidermis or could be coming from an adnexa. And we see that not only do we have mitotic figures, but we have also atypical mitotic figures. So that will qualify just by this that we're dealing with a carcinoma. Now, let's pay attention to these cells because they have the same nuclei that we see up there. But look at this cytoplasm. The cytoplasm is not eosinophilic, as we saw in the cells that are more superficial, but rather is vacuolated. And this is the important point to remember. Not only is it vacuolated, but the vacuoles scallop the nucleus. The only cell that does that in the skin is a sebaceous. And let me show you what I mean by that. So let's go to a normal sebaceous gland. And we have the sebaceous, like this one, in which the vacuoles are so large that they scallop the nucleus. In actually, in some areas, you can even have, like this, you can even have a signet ring morphology that will remind you of the carcinoma of the GI tract. So let's go back. So we have a lesion that is markedly atypical, and it has sebaceous differentiation. Now, you have two differential diagnoses, that it would be benign or malignant. Now, if you push me, the degree of cytologic atypia that we see here will be beyond what you can see in a benign lesion, which in this case will be sebaceous adenoma or sebaceous epithelioma. But let's ignore for a moment the degree of atypia and the presence of atypical mitotic figures. The other feature that will help you make a diagnosis of carcinoma in a sebaceous lesion would be the presence of pagetoid upward migration, meaning the cells that we saw that they were invading the epidermis, for example, this one, admixed with the normal keratinocytes. This process of pagetoid upward migration or pagetoid extension, it's only seen in sebaceous carcinoma and not sebaceous adenoma or sebaceous epithelioma. So one thing, we made a diagnosis of carcinoma that depending on which area of the body is more likely to be associated with metastasis than regular basal cell carcinomas or squamous cell carcinomas. And second, and this is important to remember, these patients, particularly if the lesions are outside the face and the head and neck, the patients are at much higher risk to have Muir-Torre syndrome, which, as you know, is a microsatellite instability syndrome, and those patients are at a higher risk for developing polyps in the colon and carcinoma. And if I may brag a little bit, one of my moments of most success was when I was talking to my chairman in her office, and sorry, chairperson in her office. And then at that time, a clinician called her and told her that she wanted to thank me, but because he didn't know that was in her office, for making the suggestion of possible Warty syndrome in a patient, because after making a diagnosis of a sebaceous lesion, the patient was scoped and it had an in situ adenocarcinoma of the colon. Now, let me jump. Just highlighting the scalloping again. Scalloping is not diagnostic of epithelial lesion because you can have the same scalloping in renal cell carcinoma, and you can have the same scalloping in clear cell melanocytes. So melanocytes, whether benign or malignant, can have also this scalloping. The other two situations in which you can suggest with almost certainty that the patient has Warty syndrome is when you have a sebaceous lesion like this one with a prominent cystic formation, or when you have a proliferation of keratinocytes forming papillae resembling those that you see in keratoacanthoma. Those two situations are almost always associated with Warty syndrome. And there is a marker that we use frequently, and it's adipophilin. Adipophilin labels the cells with sebaceous differentiation with vacuoles, like this one, that have a rim. Those are the vacuoles that you see in SIBO. And in contrast, vacuolated cells like this one, there are macrophages. They can have vacuoles. Clear cell carcinoma can have vacuoles. But if you notice, the vacuoles do not have the nice hole and the nice membrane morphology. So that would be a way of helping determining if the vacuolated cells are SIBO or not. And to confirm or to support the interpretation of possible Warty syndrome, you can use the antibodies against the four enzymes, MLH1, PMS2, MSH2, and MSH6, excuse me, that they go in pairs. And if you lose PMS2, you will lose also MLH1. If you lose MSH6, you will lose also MSH2. And that's also a way of supporting the diagnosis. Let's move. And we still have a few more minutes. This is another epithelial lesion that it has very distinctive pattern of growth. So if you notice a low power, it has a jigsaw morphology, but it's not the jigsaw morphology that you see with an acrine spiradenoma or cylindroma, in which you have the clusters of epithelial cells, they are opposed one to each other. But rather what it seems that you have very peculiar morphology of the nest of epithelial cells, and you have a stroma that is heavily infiltrated by lymphocytes. The old term for this lesion was cutaneous lymphadenoma, and a kind of a benign counterpart of a cutaneous carcinoma. And that's the one that you see in the head and neck, particularly in the pharynx and then in the larynx, and associated with the EBV infection. So this lesion is now considered to be a type of trichodenoma. And because of this morphology, resembling that what you see in an Adamantinoma of long bones, it's now described as Adamantinoid trichodenoma. Those are benign lesions, and to my knowledge, they haven't been reported to either metastasize or to become malignant. Okay, so we still have a few more minutes, so let me go. Another lesion. That has preserved epidermis. If any, it may be slightly thicker than normal because the rigid ridges, rather than having the normal thickness, which would be this, they are blunt. So there is epidermal acanthosis, which if I go low power, we probably can explain this epidermal acanthosis because of the dermal process. That is not only in the dermis, but also in the subcutaneous tissue. Now, this process has different areas depending on the amount of cellularity. So let's concentrate on this one. We have clusters of dark cells, which are likely to be lymphocytes, admixed with areas in which we have cells that are basically occupying the entire dermis. And so let's see what they are. First, we confirm that we have the lymphocytes admixed with plasma cells, maybe lymphoblasts, centrocytes, endothelial cells that we have. Now let's go to the area that was lighter. So we have plasma cells, we have lymphocytes, and we have these larger cells. These larger cells have eosinophilic cytoplasm. Then look at the nuclei. The nuclei are large, they have visible nucleolus. And then if you remember the very first section that I showed you, the cells that I interpreted as macrophages have very similar morphology. Now, obviously, I'm just leading you to what I think the diagnosis is. And still we have lymphocytes, large cells with large amounts of cytoplasm. Now, these cells have something else that is interesting. We see a nucleus, but what is this cell? This cell is basically the same as the lymphocyte that we see here, correct? Now let's go to another area. This is another macrophage, and we see that it has a lymphocyte, another lymphocyte. This macrophage seems to have two neutrophils within the cytoplasm. And we have, oh, this is probably the best of all the cells I wanted to show you. So we have a nucleus of the macrophage. This would be the membrane of that macrophage, and we have these, and these, which are fragments of inflammatory cells. So this process is called emperipolysis, and obviously by now you know what the diagnosis is. One way of confirming the diagnosis will be with this marker. This is S100. If you have any doubts which marker this is, you can go, if you know the internal control, you can see that this marker is labeling dendritic cells in the mid epidermis, likely Langerhans cells, and is labeling smaller cells that are present in the basal layer, which are probably melanocytes. So now let's go to the main lesion. And we see that these are the areas of lymphocytes. In between the lighter areas, we see that most of the cells are S100 positive. And this is one of the best applications of this marker. If this is the cytoplasm of the macrophage, you can see that there is a cell there that is negative. Let's go another one. Here we go. So this is another macrophage that has either a lymphocyte or a plasma cell. And another one, another one, another one. So S100 not only does it allow you to determine that these macrophages are S100 positive, but also highlights the presence of emperipolysis if you had any doubts. Now, obviously, as you know by now, this is Rosai-Dorfman disease. It's also called a massive sinushistiocytosis. These patients may have single lesions, which is the most common scenario in which we find these specimens. because for our colleagues in hempath or general pathology, it's more common to see it in lymphocytes, and that's why it's called sinusocytosis. It's still unclear if this is a neoplastic process or if it is a reactive process. The patients have multiple immune alterations, and from at least our point of view, the majority of these patients have, that's another beautiful and peripolysis. The majority of these patients have a good prognosis. The ones that have the disease. Hello? Yeah, we have 5 minutes. Is that Dr. Davis? That's what you were saying? Okay. So these patients with a localized disease have a good prognosis. So let's see. Let's see. Actually, let me go to the last one. And I promise that if Dr. Davis invites me for another.
Victor, that's fine. Just we're not locked into an hour, so please feel free to discuss.
Okay, so
that's fine. Love to hear your comments.
So let me take 5 extra minutes to finish. So
Perfect.
this is a very interesting lesion that has, just by the pattern of growth, it has a third of the diagnosis. Because, and what do I mean by that? Let's ignore for a moment the spindle cells, which obviously are abnormal. But let's look at the fat here. And please notice that in contrast to what we see in dermatofibrosarcoma protuberans, which would be all throughout areas like this one, a so-called honeycomb pattern, in which the tumor cells infiltrates diffusely among adipocytes. In this one, I don't have to push you much to tell you that this fat is part of the tumor. Because if you notice, the tumor is growing here, it has a big lobule that is not infiltrating the lobule. Really appears that this tumor has a combination of fat and the spindle cells. Now, if we go on the spindle cells, we have two components here too. Let's go to the prominent one, like this, in which it really resembles that of either a nerve or the fascicles that you can see in a fibrosarcoma, in the sense that you have tightly packed fascicles. So that would be one component. And then the other component that is typically seen is this one, in which we have cells that have a spindle morphology and they have a dense collagen stroma. So we have three components. We have fat, we have the densely cellular fascicles, and we have the hypocellular areas with fibrosis and spindle cells. So if we had only the densely packed fascicles, we could be dealing with a neural lesion. And if you push me, we could suggest that this could be a smooth muscle. If we had only these areas, it would be perfect for a desmoid, or the combination of fat and those fibrous areas would be perfect for the spindle cell lipoma. And obviously, if we only had the fat, it would be a lipoma. If you put all three together, and this is a lesion that is very common in young patients, and that's why part of the diagnosis is infancy. So this is a fibrous hamartoma of the infancy. And the infancy has been dropped, and it's because even though it's majoritarily seen in infants, and up to a number of these cases can be congenital, can be seen also in adolescents and in adults. So that's why the preferred term is that of fibrous hamartoma. So the key to the diagnosis is to remember that it really looks like a hamartoma because you have the benign adipose tissue that appears to be component of the lesion. And then if you look close enough, you have the spindle cells mimicking either nerves or fibros, some of them with a more undifferentiated, because you have this, you could call it a nerve, but this will be hard to call a nerve. And the other component in which you have spindle cells resembling those of a desmoid tumor. So let me move to PowerPoint. And it has been associated, at least in a few cases, translocations. And just to emphasize that 23% of the cases can be congenital, and primarily those and the flexural regions. Axilla is the most common one, proximal arm, upper trunk, followed by groin and the genital area. And why are they important? Because they can recur. And so therefore complete excision is recommended. So just highlighting the fusiform cells, the fascicles with those mesenchymal cells resembling nerves. And in some cases, obviously, if the lesion is big enough, they could have actual nerves. So let's go back. This is one of the lesions in which it pays to look at the periphery. The same as you can tell if a nevus is better a nevus than a melanoma because nevi tend to end with nest and they're well circumscribed. This lesion, if you look in the center of the lesion, you may be misled because it may be very difficult to determine what the differentiation is. If I tell you that these cells are S100 and MART1 positive, I can sell it perfectly as melanoma. If I tell you they are CD30 and CD45, this is an anaplastic large cell lymphoma. If I tell you there are CD3 and CD4, it's large cell transformation of mycosis fungoides. But if I show you the periphery, we have this. Now, this could be acantholysis, as what we saw in the Warty dyskeratoma, or it could be something else. So let's keep going. Even more at the periphery. Here we go. Now, one of the things that is helpful is this. Please notice that in this space, not only do we have these tumor cells that seem to be floating, but also we have red cells and maybe a lymphocyte and maybe a neutrophil and more red cells, more red cells. So this should be the red flag to consider other possibilities because 25% of these lesions are keratin positive. So if you are convinced that this is a carcinoma, possibly metastatic to the skin, and you do keratin, you will be wrong in the diagnosis because you have to go further. And because of the fact that we have this area, you have to consider the possibility of vascular differentiation. So these tumors are ERG positive in the majority of cases. They tend to be either CD34 or CD31 positive. And then WT1 can be positive too. And if you're using some of the older markers, factor 8 related antigen is also positive. So the most important thing of this is to realize that despite being so solid and so epithelioid, it can be something else. And I believe the other half is the same. Yes. Okay. Another important thing is these tumors are very aggressive. The two scenarios in which we see them in Dermpath are one, sun-exposed skin, which is this one, which is typically associated with old age. Well, I have to be careful about old because it's getting closer to me. So let's say more advanced than what we have now up to this point. And the other one in females receiving radiation therapy after a mastectomy or after, well, mastectomy will be unusual to receive radiation therapy after lumpectomy. Those are the two most common scenarios. And let's go to the last one, but not least. Now, this is one of the situations in which an inflammatory or an eruption can be biopsied as a shave. And actually, my mentor, Dr. Scott McNutt from New York, used to recommend our clinical colleagues in dermatology, whenever they had suspected this diagnosis, to do a shave, because shaves allow you to have more surface of the epidermis than a punch. A punch gives you more tissue deep, but is narrow in the epidermis. And why is that important? Well, because you want to see primarily the dermal epidermal interface area. So please notice that we have areas in which we see not only the epidermis, but we see something else in the epidermis. We see, and basically nothing in the dermis. We see other areas in which we have both in the epidermis and in the dermis. And we have areas in which it's primarily those cells that we see, they are in the dermis. So let's just start with the epidermis. And what do we see? Let's go to an area that will be relatively easier. So this will be the normal epidermis. So we have basal keratinocytes, probably a melanocyte. And there is something here that is unusual because it's very hyperchromatic. So let's concentrate on this area because it's even more interesting. We have the basal keratinocytes, possibly a melanocyte, and we have a cluster of cells that have very, very dark hyperchromatic nucleus, which is abnormal. And actually, let's see if I can make. Okay, so now what I did is I zoomed completely. Look at the contour of this cell. I apologize because obviously it's completely pixelated. But if you compare a nucleus of a keratinocyte, you see how smooth it is? These guys are spiky. Despite they look like they were oval. Oops. Okay, and sorry. It has blocked.
Can you try reloading it?
Well, I don't know what it did because it changed completely the magnification. It went like berserk.
That.
And I'm just going opposite with a. Now, it's actually even. It's not even allowing me to. Okay, hold on. Let's see if I can. Here we go. Okay. Let's go back. Now I really made it tiny. Yeah, here we go. Here we go. So now you can tell that it's really true that we are live. Okay, so let's go back. Hopefully it's gonna allow me to do it now. So we see the cells that, remember I just showed you how spiky and how irregular they are. And let me again just remember my mentor, Dr. Scott McNabb, because one of his papers was electron microscopy on these cells. And he demonstrated that if you see more than 6 folds per cell in a lymphocyte in the epidermis, that was diagnostic of this lesion, which obviously by now, I hope everybody will agree with me that it's mycosis fungoides. And so talking about a job of counting the folds of a cell in an electron microscopy. Now, what is important to remember about this lesion? Well, the majority of the lesions, 99.9%, are going to be CD3 positive. The majority of them, more than 80%, will be CD4 positive. So that's helpful because if you have, okay, well, I was going to show you, but if you have immunohistochemistry CD4 and CD8, and you have a ratio of more than 2:1 CD4 cells in the epidermis compared to the CD8, that's very supportive of mycosis fungoides. If you have a ratio of 4:1 in the dermis, again, that's very supportive of mycosis fungoides. So CD4 to CD8 ratio is very helpful. However, in a minority of cases, particularly in African Americans or people with heavily pigmented skin, mycosis fungoides can present in young women with a CD8 phenotype. So please be careful, because if you know that the patient has a hypopigmented lesion and is young, do not expect to have expression of CD4, but rather expect to have a CD8 expression on these cells. And the other thing that is important is that if you're doubting between mycosis fungoides or some of the more aggressive tumors, particularly the gamma delta T-cell lymphoma, mycosis fungoides, it's overwhelmingly a beta, alpha beta phenotype versus the gamma delta, which by definition will be gamma delta phenotype. Exception of a very rare situation in which you have patients with mycosis fungoides for many years, so therefore supporting that diagnosis, and they can present with a phenotype of gamma delta. That's very exceptional. We have a couple of papers on the topic, but just to remember that for the vast majority of cases, once you have this lesion and you want to phenotype it, it will be CD3, it will be CD4, and it will have a predominance of CD4 over CD8 cells. And I believe that 9 minutes after the hour, we completed the 12 cases. So again, thank you, Dr. Davis. Thank you, everybody. And I don't see the chat, but if you have any questions, I will be more than glad to answer them.
That is great. Thank you so much, Victor. And yeah, if you have any questions, why don't you go ahead and send them to the education at sagisdx.com website, and or sagisdx.com, and we can go ahead and answer them, or Victor, we can just forward the emails.
Perfect. And Michelle, it was Michelle, correct? Who was
April.
it? So thank you. April. So April, thank you so much for coordinating.
Of course,
Thanks,
thank
Victor.
you.
That was wonderful. Thanks so much.
Okay, so everybody have a great day and stay safe.
Good night.